Well, thank you all for being here, and thank you to Lonnie and Malar for giving me this opportunity to present my work. Today, I'll be telling you about a three-factor model that I used to predict the presence of common early-onset psychiatric disorders. Since the late 1970s, the dominant model within psychiatry has viewed disorders as discrete categories. Recently, however, there has been a shift towards conceptualizing mental health problems as reflecting the intersection of multiple dimensional factors, as encouraged by the RDoC, or Research Domain Criteria Framework. The RDoC is a research framework for investigating mental disorders. It integrates many levels of information from genomics and circuits to behavior and self-report in order to explore the basic dimensions of functioning that span the full range of human behavior from normal to abnormal. The goal is to understand the nature of mental health and illness in terms of varying degrees of dysfunction in general psychological and biological systems. This perspective is also echoed by the HiTOP, or Hierarchical Taxonomy of Psychopathology framework. The HiTOP model is a data-driven, hierarchically based alternative to traditional classifications of mental illness. It conceptualizes psychopathology as a set of dimensions organized into increasingly broad transdiagnostic spectra with varying degrees of severity. Constructs higher in the figure are more broad and general, whereas constructs lower in the figure are more narrow and specific. Preliminary studies raise the possibility that using a dimension-based approach improves the reliability and validity of diagnoses. This approach may improve case conceptualizations and align more closely with transdiagnostic treatments, while also specifying more narrow targets for intervention. It's important for us to identify factors that can help predict which individuals may go on to develop psychiatric disorders. One factor that has been shown to be linked with poor psychiatric outcome is externalizing traits. These are behaviors characterized by poor emotional regulation and behavioral inhibition, such as impulsivity. Externalizing traits have been shown to increase risk for common psychopathologies, such as substance use disorders, personality disorders, as well as mood and anxiety disorders. Another known risk factor for nearly all poor psychiatric outcomes is childhood trauma. Evidence from population-based studies suggests that children who have experienced trauma are twice as likely to develop a mental illness compared to those who haven't. What is even more concerning is that this elevated risk for psychiatric illness is present not only during childhood, but it persists throughout adolescence and into adulthood. Lastly, levels of the dopamine D2 autoreceptors in the midbrain have also been linked with impulsivity. Normally, when these receptors are activated by circulating dopamine, they inhibit further dopamine release. However, if there are insufficient D2 receptors in the midbrain, dopaminergic autoreceptor regulation goes wrong, and this has been associated with increased impulsivity in humans. We wanted to focus on the midbrain specifically, since this is where the cell bodies of the mesolimbic dopaminergic system are located. A commonly used method to measure the availability of D2 receptors in the midbrain is with PET imaging and the tracer fallipride. It has been found that individual differences in midbrain fallipride binding values correlate negatively with striatal dopamine release and impulsivity-related traits. This image shows that the influence of decreased midbrain dopamine autoreceptor availability on trait impulsivity is mediated by stimulated striatal dopamine release. Our lab has also found that individual differences in midbrain fallipride binding correlate with an impulsivity-related feature known as sensitivity to punishment. Here, lower midbrain fallipride binding values were indicative of low sensitivity to punishment. Given these correlations between midbrain dopamine D2 receptor levels and impulsivity traits, which are risk factors for psychopathology, we thought it would be important to include a measure of midbrain dopamine D2 receptor levels in our model. Therefore, the aim of the study was to determine whether this three-factor model consisting of externalizing traits, early life adversity, and midbrain D2 autoreceptor levels can predict which participants currently or previously had psychiatric disorders. To do so, we collected data from 52 participants who were followed from birth. They were born between 1996 and 1998 and lived in the Montreal or Quebec City areas. Our sample consisted of 30 females and 22 males. Participants were tested at age 18 and then followed up for the next 3 years. 41 of our 52 participants had one or more follow-up interviews. Externalizing traits were measured annually between ages 10 and 16 using the Social Behavior Questionnaire. To obtain psychiatric diagnoses, participants were interviewed using the Structured Clinical Interview for the DSM-5 or SCID. To measure early life adversity, we used the Childhood Trauma Questionnaire or CTQ. And to measure levels of dopamine D2 receptors in the midbrain, we used PET imaging and the radioligand falipride. Falipride is a high affinity dopamine D2, D3 receptor antagonist with greater affinity for D2 receptors. PET scans measure binding potential non-displacement values of the tracer, which allow us to estimate the receptor availability in the regions of interest. We ran a binomial logistic regression to test whether this three-factor model could identify which participants had lifetime history of psychiatric disorders. We tested this once for diagnoses obtained at age 18 and again including diagnoses obtained at age 21. By age 21, 30% of participants met diagnostic criteria for one or more lifetime psychiatric disorders. These included substance use disorders, mood and anxiety disorders, ADHD, binge eating, and more. What we found was this three-factor model was able to identify participants with and without psychiatric illnesses with 90% accuracy. The area under the receiver operating characteristic curve was 91.5%, which is considered an outstanding level of discrimination. The model also had a very strong chi-squared value and a very small p-value. When looking at the contribution of each factor individually, while controlling for the influence of the other two factors, midbrain D2 receptor levels and externalizing scores reached significance, with CTQ scores reaching marginal significance. After including the diagnoses obtained at age 21, the model remained statistically strong and robust. Together, these results add to the evidence that many early onset, commonly comorbid psychiatric disorders emerge from the varying expression of shared risk factors. Moreover, our results provide the first evidence that the specific factors include the combination of externalizing personality traits, early life adversity, and poor inhibitory control of midbrain dopamine neurons. The data reported here raise the possibility that these features can prospectively predict susceptibility to a wide range of mental illnesses. Overall, these results have implications for improving our understanding of the etiology of psychiatric disorders as shared or discrete, the nosology as dimensional or categorical, as well as early intervention and treatment targets, which include childhood adversity, mood and impulse control, and dopamine regulation. With that, I'd like to thank my supervisors, Marco and Sil, for their ongoing support and guidance, to the website Laird Statistics, which is where I learned how to analyze and interpret my data, as well as the data collection team. Last but not least, I'd also like to thank you for your time and attention. And now I will take any questions.
Thank you very much, Maisha, for this very interesting talk. I don't see any questions in the chat right now. I'd like to know, so you considered the various outcomes together, because that's really the point you wanted to make, right? That there are shared mechanisms. But did you just, in terms of an exploratory analysis, also look for whether for certain disease outcomes, there were different predictors or different patterns of predictors, where maybe externalizing behavior or childhood trauma were more strongly contributing?
More strongly contributing in predicting certain specific
Yeah, exactly.
so the analyses, some other analyses that I ran were to see if this model could predict substance use disorders, and that was a very strong model, as well as we can probably imagine. But when I ran the model to predict internalizing disorders, for example, I included major depressive disorder as my outcome variable. The model was strong, but the only issue with that is our sample is really small. So I think we just had maybe 1 or 2 individuals with major depressive disorders. So I would really question the validity of the statistics there. Like, I don't think there's enough statistical power to just make those type of conclusions yet, unfortunately.
Yeah, that makes
sense. I hope that answers your question.
Yeah, definitely. Thank you. Mala, you have a question?
Yeah, very lovely talk, Maisha. Really interesting stuff and a really interesting and kind of innovative analysis. I mean, just to that question, I'd be interested in knowing what were the outcome kind of disorders that you had.
Yeah, absolutely. I can share my screen again and show you. They included, so these were the list of my disorders, if you can see. Yeah. Yeah, so we had substance use disorders, mood, ADHD, panic disorder, generalized anxiety disorder, adjustment disorder, dyslexia, binge eating, and conduct disorder. Yeah.
Very interesting. That's quite a range of variety of different disorders.
And did anyone fit into multiple, or did anyone have multiple diagnoses? Given your introduction, especially about the spectra and the transdiagnostic nature of a lot of psychiatric disorders.
Yes, absolutely. We did have participants with more than one diagnosis. And so that would be referred to as comorbidity, but we had participants who had simultaneous comorbidity, but also sequential. So if they had one disorder now, in follow-up, they developed another one, for example.